Welcome to COBRA on this freezing Monday morning in Johannesburg. Thanks so much for joining. My name is Maurice Crespi. I'm the managing partner of Schindler's Attorneys. Schindler's Attorneys is a co-founder of COBRA. We founded COBRA together with IQ Business and Engaged Business Turnaround. And the idea is to put together a pool of resources, a pool of companies, a pool of businesses who are prepared to assist businesses in distress in any way they can. So we have now over 55 partners across a whole range of professions who are prepared to meet with businesses, representatives of businesses in distress on a pro bono basis. We set up private Zoom sessions with you and your team or you and your staff. We also have a fantastic, unbelievable knowledge base on our website, www.cobra.org.za. And what we also do is we provide these informative daily webinars where we get industry experts and we get insight from these experts in this time of need. So today we deal with the medical aid schemes running the COVID-19 gauntlet together with their members. We have Jeremy Yatt and Mark Hyman who will be discussing the schemes and the situation that they find themselves in the COVID environment. So just a bit about Jeremy. Jeremy holds a BA LLB and he has more than 20 years healthcare experience and has an intimate understanding of Fedhealth, having previously been the CEO of Fedhealth between 2003 and December 2009. During that time, Yatt was closely involved in the strategic planning, financial and operational industry and brand management of the scheme and was instrumental in growing the member base significantly. In 2014, Yatt was appointed chairman of the scheme. He has subsequently resigned from the board and the new chairman will be elected in due course. He will head the scheme at a time when the industry generally is grappling with stringent legislation, ongoing competition commissions, market inquiries, as well as a subdued Southern Africa economy, which is impacting negatively on medical scheme growth. He said that the changing medical landscape and the introduction of various new regulatory issues has placed increasing pressure and responsibility on schemes. Mark Hyman was born in January 1951 in Boksburg. He's a practicing Orthodox Jew. He's the owner of Merin Financial Services, South Africa's third largest third-party facilitator of MasterCard products and solutions in South Africa. And he's the founder and director of NFS Shell 2018, which is a SAFTU and NUMSA union-related development company, and Burma Holdings, which is a diversified, innovative company servicing the private medical and broker sector via Medicheck, as well as forensic audit divisions, BB Forensics. So guys, thanks so much for joining. We're really, really grateful and we're indebted to you. Before I hand over to you, Mark, let me introduce the balance of the panelists. We have Emma Marseille from IQ Business, Adam Kraker, the CEO of IQ Business, who I haven't introduced, in fact, is Dr. Osborne, I see is on the line. We have Gary Barachowitz, who is from Schindler's Attorneys, and Renee Klopper, who is from IQ Business. So, Mark, thanks so much for being here. Over to you.
Thanks very much, Maurice, and to all the panelists. And a very big thank you to both Dr. Osborne and to Jeremy for being with us. I think that we're sitting in a situation, not only in South Africa, but throughout the world, but more particularly in South Africa, where we unfortunately, uniquely are placed in a situation where South Africa, which normally wallows at the bottom of any survey environment for education, etc., at the bottom of the list of 200 countries worldwide, But we're unfortunately in a situation in South Africa where we're currently, as of last night, fourth in the world in terms of the pandemic of COVID hitting our shores. As of last night, we had 276,242 active total cases in South Africa, with a total recorded number of deaths of 4,079. At a webinar that I attended yesterday afternoon with Dr. Richard Friedland, in this respect, I think it was clearly put across that that number of deaths of 4,079 are only deaths that are recorded in hospital and not at homes. And the morbidity rate that we're finding, I think, is of quite great concern. I think the other area of concern, and having looked at the annual report for Fedhealth, and your break of your current membership, if one looks at that, your membership demographic is very much leaning towards a Gauteng base, where you have 33,000 members out of a total of 79,000 in the Gauteng area. So that is quite a concerning factor with South Africa, with Gauteng having become the epicenter of the COVID pandemic. Also, interestingly enough, to see that the private sector is quite clearly leading the race in terms of the number of tests done, which must be impacting quite dramatically on medical aids. And the public sector only conducting approximately 957,000, with the private sector at almost 1.2 million tests. So I think if I could lead off with you, Jeremy, if you don't mind, if you could unmute and put your screen on, some background as to how you see medical aids in South Africa, where you see it. And Dr. Osborne, thank you very, very much for stepping in at the very last minute with Dr. Simon having to attend an urgent court session. It's really appreciated, your attendance at this very, very last minute. So Jeremy, over to you.
Thanks, Mark. I think just what I was quite keen to do was to just give the attendees a bit of an overview of medical aids and what they really, the structure of them, because I think a lot of people have the sense that they are a sort of a for-profit insurance type of company with shareholders and bonuses that get paid out to management and that sort of thing. And it's not like that at all. And I think the nearest we can probably approximate in this country is a stokvel, where people put money into a pool and use it for certain purposes that will benefit all the members of that particular entity. So we are here to defray members' medical expenses, and it's a fairly complicated structure that we have in terms of how we pay, and doctors have to have certain codes, and it can sometimes be quite bewildering. And when you look at the numbers in terms of money that's involved, it can be quite staggering, sort of vast amounts of money. And of course, as every medical aid member will know, it's an expensive enterprise. It's expensive to belong to a medical aid. And sometimes you might feel you pay all this money, and then when you have a problem, the medical aid starts giving you gears about what it will cover. So there are reasons for this, and it's certainly not something that we do lightly, just for the fun of it. The important thing is we're a not-for-profit entity, but we do have to generate reserves, and we do have to generate surpluses in order to create those reserves so that we remain sustainable. So every year, medical inflation increases at about double the inflation rate of the country. Every year, new drugs are found. Some of them are fantastic. The latest advances in cancer drugs, immunotherapy is brilliant. But one course of Keytruda can cost 1.7 million rand. And while it seems to be working better than some of the previous treatments used, it's a lot of money, and we have to now try and manage all of that, along with all the day-to-day costs and expenses that people incur. So when medical aids sort of are quite prescriptive about where you receive your treatment or how much they will pay for it, It's all with the intention of making the medical aid sustainable. So in an environment like we have now, where unemployment is increasing, incomes have been constrained for various reasons, we obviously look at the situation with a fair amount of anxiety or trepidation, because it's not just about whether there'll be an increase in claims because of this pandemic, but rather a decrease in revenue for the scheme as more and more members struggle to afford their medical aid. So, we have been approached by a number of organizations to say, what can we do to assist? And the reality is actually very little, both in terms of the legislative environment and in terms of the financial environment. So schemes are obliged to have a reserve ratio of 25%. In other words, of the annual contributions that the schemes receive, they should have at least 25% available in investments and the like. This is a necessary buffer in case there's a massive run on claims, but it's also fairly useful as an alternative revenue stream from the investment income that we earn from it. Of course, right now with the markets being what they are and the interest rates being what they are, it just adds to the pressure. So it sounds a bit strange when a scheme has 1.5 billion rand sort of under its mattress, and yet it's sort of pleading poverty and saying, we're struggling to pay claims and we could be under the whip a little bit, and which is why we cannot afford, and our actuaries did the sums, we cannot afford to give members contribution holidays. So in other words, a contribution holiday is where you don't pay but you continue to receive the benefits. We worked out that we would deplete our reserves in the space of 2.5 months if that was the case. The other initiatives that we've looked at is if a member or a small business, for instance, finds itself unable to pay the contributions, rather than terminate the membership, which is what our rules would oblige us to do if we don't receive the contributions timelessly, we've allowed for the suspension to continue, and that either the member can make good the shortfall and continue to receive the benefits over the period that they maybe weren't paying, but which they have now subsequently paid the arrears, or in fact rejoin the scheme at a subsequent date without underwriting. Now, these are probably small efforts or advantages for members during this time. But like I say, there is really a limit to what you can do and remain sustainable. The costs of treatment, not just for COVID, but normally, are significant, and we need to be around for our membership base. Mark, do you mind can I talk a little bit about COVID and pandemics? So the last time we had experience with a sort of pandemic was with HIV/AIDS, and I remember in the 90s, as an industry, we were scratching our head and thinking, how do we deal with this? And the real fear that we had at the time wasn't so much about the cost, or about the effect of on people not being able to be cured, because there was this idea at the time that HIV positive was a death sentence. It was that if the cure was found, or rather if the treatment was found, what the effect would be on medical aids, on funders. And it's got to the point now at this stage where we have an HIV program. Most medical schemes, I'm sure, do, and members who test positive for HIV are put on the program and they are able to access the medicines. And members who have HIV and who are treated in this way cost the scheme way less than other members who have hypertension or diabetes or other types of conditions. So it's quite a sort of sobering thought to think that we've gone from a position where it was doom and gloom with the HIV to one where it's actually quite manageable and continues to improve. Every year brings better advantages, not just in curbing transmission, but also in treating the symptoms and some of the sort of problems that can be associated with it. In COVID, these are early days, so we sort of are now still grappling with what the effect will be on the scheme. We find that about from our, the information we have from our own membership, and this could obviously vary from scheme to scheme, members who test positive and need to be admitted generally spend about 7.5 days in hospital. So that's the average thing. And the cost of that is working out, if they have to be in ICU, it comes in at about between 160,000 and 180,000 Rand. If they don't need to into ICU, in other words, they probably don't need to be ventilated and can just have high airflow or oxygen flows and treated with blood thinning drugs and the like, then that's working out at only about 16,000 Rand. And if they don't need to be hospitalized at all, the cost to the scheme is in the region of 2,500 Rand. So it's a massive variance that we have. The disturbing stat is that of our membership that goes into ICU, 42.5% survive. And that is something that is obviously a concern, because just about every single person that falls victim to the disease has a number of comorbidities. They have, and prime amongst them, diabetes and hypertension seem to be the factors that aggravate the symptoms of the disease. So the effort must be on how we actually manage people with this. So it's so important not to contract the disease in the first place. And I don't think you can be a sort of cavalier about it and say, oh, well, if I get it, I get it. If I don't, I don't. It's like, try not to get it, because you don't know what the effect will be. It could hit you and pass, or it could hit you and you stay hit. So we certainly are concerned about the effects that the disease will have on the scheme's finances. But the bizarre thing is that right now, due to a lack of elective procedures being done, a decrease in the number of elective procedures being done in hospitals, the scheme, the financial pressure right now is not on the scheme. So we would normally see people having a lot more elective procedures. To be clear, an elective procedure isn't cosmetic surgery, although that can be, but it's usually things that don't have to be done right now, otherwise you will die, such as a knee replacement or a corneal graft, or there are any number of procedures. A hernia operation can actually be classified as elective, and which is why if you were in other jurisdictions like the NHS in the UK, you can sometimes wait a year or so to have your knee replacement done, rather than where in this country where people see a doctor and next week are booked in for the procedure. So it's got to a point where many practitioners in the country, and perhaps even some hospitals, I don't know, Mark, you were talking to Richard yesterday, you could maybe give us more information about that, are seeing a reduction in their income. And we've been approached by certain provider practitioner forums for some kind of assistance to say, look, can't we help them out during this period, because they're not receiving the kind of money that they were normally receiving. And it's something that we have to engage with them about, because our medical fraternity is vital to this country, and we can't have them leaving the country because they're not making a living here, or leaving the profession because they're not making a living out of it. So it's something that is of grave concern to us. At the same time, how we would structure that kind of assistance is even more complicated than how we run our businesses when we don't have a pandemic of this nature. So the weird effects of this is that, you know, we have stories that the hospitals are so full that you may not get a bed, but then you have other hospitals saying, no, we actually have plenty of space available. The information that goes around about do we need to dig 1 million graves and that sort of thing creates a lot of anxiety. We've seen every year we offer our members, and I say we, it's actually the industry, but Fedhealth in particular, we offer members an opportunity to have a flu vaccine, and some members take it up. This year, the flu vaccine in the country's been sold out. There just isn't any available. It's all been used up. So people were anxious about, I think, just generally contracting flu or anything, and so they all went and had the flu vaccination. But at the same time, because of the effects of isolation and wearing a mask and social distancing, people aren't contracting any of these diseases, which is great. And as a result, the pharmacies are seeing a decrease in their sales of products like Corenza C and Advil or CS or that type of thing, as well as we are seeing a reduction in the amount of antibiotics that are being prescribed by doctors normally because you've got, you know, associated infections with flu or colds. So it's been an absolute roller coaster. We just have no idea what to expect. We think we're doing fine, then suddenly it becomes, you know, hectic, and then, you know, the anticipated tsunami of admissions doesn't happen, and now it looks like it is happening, and all of this creates an enormous amount of uncertainty in the way in which medical schemes can manage their funds. And so, which is where we get to, you know, how we have to try and anticipate and plan for the future.
Thank you very, very much, Jeremy. I'd also like to welcome Dr. Osborne from Sizwe and Shaba at this point. Doctor, if you could give us some background in terms of the Sizwe medical scheme, and you're currently involved, and I think that it's possibly a court case at the moment with regarding your possible merger with the HOSMED initiative between the two schemes. But if you could give us some idea from a Sizwe perspective, and give us some background on Sizwe, where you sit currently on about 46,000 members in your scheme. You're a blue-collar scheme. You sit at a solvency ratio as of the 31st of December, 36.7%, on a membership base of just over nearly 47,000 members, with a reserve per member of 19,000 Rand, and your reserve fund sitting at almost 1 billion Rand. So if you could just give us some background in terms of where you see Sizwe as a scheme, and where you see it taking, and the effects that COVID-19 has had on your particular scheme for the blue-collar worker, who's possibly been terribly affected by the unemployment and the retrenchments that have taken place, and people not being able to get to work. Over to you, Doctor.
Okay. Good morning. Just the first correction. Dr. Mahanjane couldn't be here, so I'm Dr. Nomonde Mabuya. I had to step in to cover both of them. I'm from 360 Health. We are no longer Sichaba. So, but I'll give that perspective. Just in terms of where we are sitting at around 47,000 members, and we have also been affected by the COVID-19. Just in terms of total cases, we've seen an exponential growth from the 27th of March to now. I mean, we've seen cases growing up from 203 in April. In May, they went straight to 946. And up to the end of June, we are sitting at 2,889 cases. So it is a very sharp exponential growth curve that we've seen with cases. And in terms of the cases themselves, you know, we've sort of looked up to that huge number of cases, but the costs themselves vary. If you admit somebody to the ICU, we also have a case that is in ICU for 36 days. That case is running in the region of about 800,000, just one case alone. And your average case that sits in a private ward, they tend to be in a private ward for about 2 days. And, that cost is also not very comfortable. So really what we are seeing with COVID-19 is that the costs are very high. And in reality, your total average cost for hospital admission is currently at around 70,000 per case. So minimal single event costs for the scheme could run, if somebody stays in general ward for 2 days, that's a cost of about 3,550,000 for only 2 days stay. And if somebody stayed at the ICU with a ventilation, maybe for a few number of days, that cost goes up to about 200,000. So the costs are not very comfortable. And I do confirm that we are very worried about the reserves, because this could be wiped up in a matter of 2 months. So we have received a few requests from a few employer groups asking for contribution relief. We unfortunately couldn't sort of give them, but we've also taken the view that if you cannot manage to pay for 2 months, we will let you not pay, but also you won't necessarily get the reserve, but you can bring back your people in 3 months without underwriting. So we've sort of gone on that route. We've also received requests from doctors themselves wanting some assistance because now their cash flow has been wiped out completely. So, we are sort of looking at the cases and sort of seeing where can we come on board. Issues around telehealth, we are still making sure that we can respond to that specifically. There's also a new request that they want to be provided with PPE as a cover. So those kind of things, we are also looking at them to make sure that we don't get the skills flight because we are not able to sustain the income of our doctors. But it's a very dicey one because you can't necessarily commit. You need to look at the rules, which are very tight, and we can't necessarily commit to certain things that are not necessarily compliant in terms of the CMS regulations. So really schemes are facing a very difficult time. There's a lot of retrenchments. So even some of the employer groups we have, you're not even sure if you'll be able to continue collecting contributions because the economy is not growing and the people are losing their jobs. So it's a very, very, very challenging time for everyone. And also where we are worried, we looked at the 1918 pandemic in terms of the history of what happened then. That pandemic ran for 18 months and it had 3 waves. So the issue of looking after the cash tightly becomes very critical. So our cost containment measures, we've also implemented cost containment measures so that we don't necessarily use the hospital to self-isolate people. People must self-isolate either at home or other non-hospital or subacute areas so that we manage costs. Because if this pandemic is going to be with us for 18 months, we then have to be very tight in terms of how we disperse funds. I will pause there. Thank you.
Thank you very, very much, Doctor. There have been 2 interesting questions that I would like to pose to both panelists. One is from Brian Shipping, which I see, Jeremy, you have responded to, but I think that maybe it's for the wider audience to get an understanding. And Brian's question is there no business case to encourage testing and paid for by medical aid and proactively prevent aggravated situations which will eventually cast more based on the delay of knowing whether a member is affected or infected? If both panelists could talk to that one. And there was also a comment in the chat box, which I just need to get to, if you give me a second, and that came through from, I'm just trying to find it, from Maggie Bossoff, who had said and I assume she was talking to your project, Jeremy, that she said, thus far we've seen very few membership terminations due to COVID. The extended suspension period concession certainly gave some peace of mind. So if we could possibly address those 2 issues. And also what I would like to try and understand from both panelists is that in my discussions yesterday with Dr. Friedland and Professor Barry Shub, there was a very interesting comment that we are seeing in South Africa approximately a 30% false negative reading or reporting coming back on COVID-19 testing. Now, we fully understand that medical aids are and have received the directives that came through on the 7th of May with regard to COVID-19 being regarded as a prescribed minimum benefit. However, medical schemes have adopted the attitude, if you come back negative, you will be responsible for the payment of that test, which can range between 800 and 1,500 Rand, depending on the test done. Is there any way that you believe that the schemes can mitigate? Because the false negative, in actual fact, is as equally as bad a problem as a positive result.
Mark, who should go first? You're on mute now, so I can't hear you.
Okay, you can go. I'll go after you. It's fine.
Thanks, Dr. Nomonde. You know, when the whole pandemic first started, the mantra was testing, testing, testing. And that sort of sounded great. It's like, yes, we need to know where everyone is and then trace and, you know, do the contacting and the like. So the problem that we have is, firstly, there's a capacity constraint around the testing. We've had letters from several pathology groups. These are the major companies that do the testing, private sector this is, that have indicated that they will only do testing in the case of where a person is, you know, showing symptoms, has been in contact with a positive person, that sort of thing, and that they won't just do it somewhere for sort of peace of mind purposes. I think we would all kind of like to go and have the test done and know are we okay or not, particularly when the symptoms, the list of symptoms that they give you are very broad, and so they, you know, they tell you headache and sore throat and upset tummy and bit of achiness and all of that. And when you sort of my age and had some wine with your dinner last night, you tend to get all of those symptoms in the morning, and they're not necessarily because you've contracted anything. It's just, you know, there are other reasons for it. Dry, high-felt air can give you a very sore throat. So it's really hard, and it'd be really nice if we had some definitive way of testing, and which is why we need something more along the lines of those antibody tests, which I know they haven't sorted out yet, where you can at least say, yes, you've had it. You had the condition at some point, even if you didn't even know about it, if you were asymptomatic, or at the very least where you could be you could have a sense that, you know, that time that you did feel a bit under the weather was because of COVID and not because of the bottle of wine. And so, you know, these are, it makes it very difficult for the population generally to have any kind of comfort about the way in which they need to sort of behave. My cousin at the moment has been running a temperature, but no other symptoms. And he's quite anxious, you know, does he have this condition? What should he do? And I don't really know what to tell him, because you can't rush off. In fact, the guidelines are don't rush off to a doctor with your temperature, but rather phone the hotline and they'll probably tell you, we'll just wait and see. So it makes it very hard for us to, as funders, to plan, and for members to sort of manage their situation without getting completely stressed about it. The false negative, I think, is the issue around the timing of when you have your test, due to the nature of the test, that you may not yet have, developed I'm not sure what you call it. I'm sure the doctor will help me here. That demonstrate that you have the disease, but yet you may have the virus working away inside you. And so a day or two later, after having received your false negative, now you will get a positive. And it's impractical to think that people can just keep going for more and more testing to try and monitor their status during the course of this disease. Doctor, I'll hand over to you.
Yes, thank you so much. It is correct that we are having capacity issues. And I think I also saw a note that DISCAM also has stopped testing, because now I think there's issues of reagents and all the test strips, things are basically running out. But I do want to mention the fact that accurate testing allows identification of people who might need treatment or who need to isolate themselves to prevent the spread of the infection. Failure to detect people with COVID-19 when it is present of this false negative may delay treatment and risk further spread of the disease to others. So incorrect identification of COVID-19 when it is not present, which is a false positive, may lead to unnecessary further testing, treatment and isolation of a person and close contacts. So correct identification of persons who have previously had COVID-19 is important in measuring disease spread, assessing the success of the public health interventions like isolation and potentially in identifying individuals with immunity. So the issue of false positive is a big issue for everybody. The reality of the matter is sometimes we measure for IgA, IgG, IgM, and they all show at different times. So the issue of testing and the delays and the false positives is also creating even more complications in our testing environment. There's no sort of clear answer around that, but I think where we are now is that we do also see a tendency of people just wanting to test because they have a fever or they are worried about something. So there's now a specific category of who needs to test. You must have a prior exposure and the temperature must be there. So you must have sort of the right profile for you to can go for testing, because we're also finding a situation that people are overloading the system in that they just want to be tested for self-monitoring or for self-isolation, and that's creating serious capacity issues. Just to give an example, for instance, at the workplace, there are two levels of testing. There's screening and there's testing. So a simple thing to do at the workplace maybe is just to screen people, check if they've been exposed, the temperature and all that. That's a simple screening procedure. But the people that you then decided they must go for testing, they must then have the right profile. Maybe they live with somebody who's positive, or an employee at work is also positive. So that's really sort of starting to help us to stratify who actually needs testing, because we are really finding ourselves in a situation where every person now wants to be tested and we are running out of reagents. And I think that's why the leading laboratories have now sent us the memo to say people who just want to know or who suspect or who might think that they have, those are not the people that are going to test. There must be a definite positive profile of direct exposure, and then you will be considered for testing. Thank you.
Thank you very much, Doctor. Really appreciate it. I think that one of the comments, and I think it's now clear knowledge based on the President's speech last night, that there are three stages to the COVID-19 pandemic that we're seeing in terms of the patient. And the first stage, of course, is the viral stage, which co-indicates headaches, body pain, malaise, supposedly lack of taste, lack of smell. And during that stage, and Dr. Friedland quoted from a professor in Scotland, where he said that if you pour yourself a strong scotch, a glass of scotch, and you sniff it, and you can smell it, then you don't have COVID-19. If you then drink it and you can taste it, you then don't have COVID-19. And that's based from the information from a very well-known Professor Johnny Walker in Scotland. So I think that's the first stage of COVID, and I think that can be dealt with to both Jeremy and to Dr. Nomonde. And that is the fact that perhaps we're in that first stage, which is the viral stage, if people self-isolated, and if they can't self-isolate, if they could get to a self-isolation center, that would take a tremendous strain off the medical scheme costs of that initial stage, which could be cured by a simple 14-day self-isolation. However, when one gets to the viral stage, which is the second stage of the pandemic, that's when a person has to be hospitalized, and that hospitalization doesn't have to be for an extended period of time, based on information that I have from the team that I discussed it with yesterday. And then, of course, you get to the third and the most difficult stage, which is the inflammatory stage. And that second stage is almost pulmonary, where the person will develop, generally, they will develop pneumonia. And that will require hospitalization, and it could require critical care, but could very well be dealt with in a general ward. And I think that the intubation process in stage 2 of the pulmonary stage, I think both Dr. and Jeremy, you're more than likely seeing from your case managers in the hospital environment that high concentrated nasocannula intervention in most instances helping, an intubation is not necessarily the road going forward. So I think that from a medical scheme perspective, I think if there was an education out there and the fear factor and the stigma were taken away, I do believe that possibly the stresses that are placed on the medical aids at the moment, from a point of view, as Dr. Nomonde had said, is test, and one got into that self-isolation and self-understanding of how to care for oneself and take the responsibility into your own hands rather than leaving them in the hands of the medical profession. I'm not saying that that's not, when I say, please forgive me, not saying not leaving them in the hands of the medical profession. I think still consult, but I think that there should be a level of self-determination of one's condition. How would you answer that? And do you believe that's a fair indication of where we're standing at this point in time?
Mark, the concept of self-care is something that medical schemes have been promoting for a long time. And, you know, in other diseases or other conditions as well, we've been trying to encourage people with, for instance, diabetes, to make sure that they regularly check their HbA1c levels, and they make sure that they don't behave in a way that would exacerbate or aggravate their condition. And with varying degrees of success, sadly not as much success as we would have liked. It would be a really positive outcome if maybe this disease taught people the value of self-care and you know, the understanding of living in a community. So it's not all about you and yourself and your condition, but about the effect it can have on people around you. Not just, you know, spreading a disease, but just the way in which if you require less treatment, it means that there are more resources available for other people to receive treatment for something that they couldn't manage, couldn't control themselves. So I think that, you know, it's a message we certainly, everyone is punting, not just medical scheme, but everyone in the country is saying, you know, be mindful and be aware of yourself and take care of yourself, stay safe. The whole message around sanitizing and the like. But we need to take that into a next level. And so we need to all be aware that science and medical science cannot just cure a lifestyle or, you know, a life approach that has led to a number of conditions, a sedentary lifestyle perhaps, that compromises not just your own quality of life, but also the overall cost of treatment that everyone, because of the nature of medical aids, everyone has to share.
Okay, thank you. Yes, from my side, the issue of self-care is an important concept, and I think promotion of self-care, preventative measures is one of the key drivers to help people help themselves. There are common symptoms that are being educated on every pamphlet, that you might have a continuous cough, a fever, fatigue, and you might need screening. And if you are tested and you are positive, you need to self-isolate yourself for 14 days. But there's also other issues around if people who have high risk in terms of comorbidities that they might have. People who are older than 60 years, who are overweight, and who could also have potential medical diseases. They could also invest in buying themselves an oximeter where they can monitor their oxygen saturation levels at home, and these pulse oximeters are readily available. There's also an issue of taking a vaccine for flu when you are at a high risk situation, and there's also an issue of knowing, exercising, keeping yourself healthy, having a balanced meal. So self-care remains a very big preventative strategy that nobody must ever take light, because it helps to minimize the number of hospitalizations, and it also reduces the issue of overcapacitating our hospitals. What we are seeing in these COVID-19 hospital admissions, the age group that we seem to be getting as a scheme ourselves seems to be between the age of 30 to up to 59. So 50 to 59 years of age, 60 to 60, that seems to be the highest number of admissions we've actually had in our own scheme. And in terms of where do we've got a breakdown of most of them get admitted in a general ward, which is slightly cheaper. But then if you are in that pulmonary phase, which you've so eloquently described, these people might need to be ventilated, and those are very expensive cases. But in the main, most people get admitted to a general ward, they do well, they can be in there for 2 days and they go home. And we actually have a high number that we discharge. It's just that getting to the decision of admitting somebody is a costly exercise, and we rather emphasize more on on self-care rather than ending up in hospital. Also, what is important at this stage of our pandemic is to be mindful of the fact that 50% of healthcare workers now are almost testing positive. So because in terms of the workplace protocols, they must be screened pre-shift before they enter into a shift. They must be tested post-shift. So we are finding that medical workers are no longer coping, be it nurses, doctors, porters, medical students, as you heard yesterday, are also on board, but most of them are also now on self-isolation. So the issue of hospitals being overcapacitated and not being able to cope is real for everybody. And hence, it puts the emphasis on self-care. And those self-care guides, we've sent most of our members self-care guides. We're almost keeping them up with text messages to make sure that they do simple things. Do not go to a shopping center necessarily. Do not attend multiple funerals. Do not do family gatherings. Those are important. Those are self-care measures that we are emphasizing in our member communication on a daily basis. Thank you.
Thank you very much, Doctor. There's a comment here from Anna-Marie Webb, and I don't know where Anna-Marie is from, but she made the following comment. We've seen a spike in requests/prescriptions for pulse oximeter monitors. Most providers are out of stock due to high demand. Our experience with schemes, chronic division, not aware of this device and drawing payment from members saving on ICD code U07,2, and I'll check that code shortly. I'm not going to quote the rest of it, and the actual device costs 850 Rand. You've made the comment, Dr. Nomonde, about the fact that people should be getting pulse oximeters to test, perhaps a thermometer to take their temperature, and only consult necessarily, and I think, Jeremy, you made the comment as well, to only consult at a time when possibly there's respiratory involvement or pulmonary involvement. What are your scheme's views with regard to the medical devices as being classified in the PMB/CDL condition, for example, a pulse oximeter? And how would you consider a home monitoring system where it would be available for people to home monitor, that you as schemes, where you currently have, for example, your care divisions for diabetes, etc., would you be interested in consider such home care monitoring in your schemes, if such, and there are those systems out there and available at this point in time?
I think
Mark, I'm afraid I can't really comment on the pulse oximeter question, as I don't have that information. I would imagine.
Yeah, I don't either, so I'll check with the council shortly.
Yeah, no, we'll look at but on a broader question, from a scheme point of view, it's always preferable to have a member at home and aware of their health status, whatever their condition is, not necessarily just COVID, and to have the tools. So, for instance, a blood pressure monitor is a great device for people who are hypertensive or maybe borderline hypertensive to have and to keep track of themselves, rather than not knowing and having to be admitted suddenly, which costs the scheme a lot of money, or just generally hypertension is a silent killer. And so to be aware of that condition. And likewise, there are a number of other diagnostics. And our concern is always just about making sure. It's one thing we can fund these things, and we'd happily do so if we knew that the member was going to use it. What we hate is funding a device that then sits and gathers dust sort of on someone's shelf and isn't used. And so firstly, we've spent the money, and second, the member isn't getting the healthcare benefit from it. But this again talks more to training or education rather than one of scheme attitude. If we could develop a situation where we are more in partnership with our members and our providers, and rather than being seen to be an obstruction in terms of access to care, I would foresee that we would do a whole lot better. I'll get back to you on the pulse oximeter thing once I've chatted to my people.
Yeah.
Doctor, any comment? Because we need to start wrapping up with a couple of last questions that have come in.
Yeah, I would say, with your high-risk individuals, the ones I mentioned before, age being high, comorbidities, it's got a role. And I think because it's a home monitoring device, it's got a place to being covered under PMVs. And it's a simple device in that it then, you can read the reading yourself. 90% and above, essentially you are fine. You're not really at risk at all. But if your reading starts to be between 90 and 94%, then you start you are in a medium risk kind of category. But it also gives you information on your oxygen saturation. It gives you your pulse reading. And, because it gives you that information, you can sort of self-monitor and you can know when to call for help. For instance, if it gives you a saturation level of below 90, that's really an action point where you cannot necessarily sit by yourself. You need help. You'd be having shortness of breath. You'd be having the right profile. So I would say there is a space for those self-monitoring devices in our promotion or in our self-care kit. Thank you.
Thanks very much, everybody. I see a question here from Wayne Malchas. And I think this is directed at both Jeremy and the doctor. With medical scheme year-end revision period closely knocking on the door, what percentage of the 2021 premium increase would be a direct result of COVID-19 and it being a PMB? Now that makes for some interesting reading at this point. And a difficult one to answer with schemes having to look at November being the time when they will start looking at their increases as we start wrapping up.
Warren, can I answer that question in November for you? I seriously actually have no idea, because at this stage, as I mentioned in our stats, Fedhealth has had a very small uptake or incidence of COVID-19 cases. And long may it stay that way, but we anticipate with our sort of particular profile of members being more at risk that it could be significant. But if they stay safe, then it won't be such a problem. So I'm afraid I can't really answer that question now. I wish I could, but obviously we will engage with all our stakeholders, the industry and our membership base around what the effect, if any, that the COVID would have on the scheme.
Yeah, at this stage, I can just maybe, I won't necessarily have an answer specifically for you there, because we need our actuaries to work on some of the possible contribution increases in the following year. But I had shared that we've seen this exponential rise, looking at 2,888 cases, and there was a 5% hospital admission rate on those. I mean, on the 137 cases that we've treated, we've already spent about 10 million, 9.6 million on those cases. So obviously, later on in the year, we need to sit down and actually work out the actual cost impact assessment on COVID-19. And once we've had that engagement with our actuaries, then we can then sort of start sharing what sort of increases are we looking at. But at this stage, it's difficult, but we do know that the cost is not small. Just a small pool of 137 cases, we already spent in the region of 9.6 million. That's just our reality.
Thank you very, very much. I think at this point, unless there are further questions from the wider audience and from the panelists, and any comments from the panelists and those people who are online, I'd like to thank you, Dr. Nomonde, for having stepped in at the very last minute. And Jeremy, as always, it's always a pleasure to talk to you, and it's always a pleasure to engage with you, and really appreciate it. But I think at this point, and we're at 10:57 with 3 minutes to go, and I'm sure Maurice wants to say some last words. But I do think that I think it's important at this point that we appreciate not only our medical aids and what our medical aids are doing for us in this country. And I seem to have lost Jeremy at this point. He seems to have dropped offline. I know you're there. Sorry. I think we need to appreciate you as medical aids. I think people don't appreciate you sufficiently, and for what you do for the 9-odd million members or lives that you cover. And I also think that at this time, I think that, Doctor, you mentioned the number of 50% of our healthcare professionals are testing COVID positive. I think that we're not giving enough attention and appreciation to our healthcare workers as well. And I would like to use this as a platform to say to you as medical schemes, thank you very, very much for what you do for your members and for members at large. And if Maurice, and I'm sure you're going to talk to this as well, if there's anything that you believe that COBRA can do to assist you, to assist your member base, whether they, particularly in the SME environment, I'm sure that Maurice will talk to that and say, you know, there's an open door to engage.
Yeah, I think it's very important to mention that it's not only big business. COBRA is about assisting all businesses from the SPASA level up. So yes, yeah, absolutely. Guys, I think that's a wrap. Is there anything else, Mark?
No, I think we might have missed 1 or 2 questions from the audience. But if we've got a recording, we can respond to them. I see there is one last question in, but you know, much more than that we can't do. I think that it is a wrap. And yeah. Thank you very much to COBRA and to the partners in COBRA, and to Dr. Nomonde for having stepped in, and Jeremy for being so willing to attend. Thank you very, very much.
Yeah, thanks, guys. And if you have further questions, just email info@cobra.org.za. Go onto our website, the further details there. Yeah, and thanks to the panelists and thanks to the attendees. Until tomorrow, thank you and goodbye.